Okay, so this next small lecture is going to introduce you to some of the other drug classes that can be used for depression and major depressive disorders. I didn't put any learning objectives in here because I don't really want you to know every single drug on the first day of psychiatry. So the previous lecture talked about drugs that I basically mapped to this particular case. These drug classes that we're going to discuss in this little kind of mini video are really kind of aligned towards the session activity and will be expanded on throughout the curriculum. The first group of drugs are the monoamine oxidase inhibitors, and the prototype here is phenelzine or selegiline. And essentially what they do is they stop the catabolism of either dopamine or norepinephrine, and to some extent serotonin, but really we primarily think of them as inhibitors of dopamine and norepinephrine catabolism, which is shown nicely in this diagram. The key thing to remember with monoamine oxidase inhibitors is that they work really well, but there are dietary restrictions that are associated with this drug that basically reduce the compliance or the adherence of these drugs, and so they're not quite well tolerated. But they work very well. And so I think just knowing that selegiline or phenelzine are monoamine oxidase inhibitors is good enough at this point. We'll do more pharmacology on these drugs in a couple cases. The other group of drugs that I want to describe are the tri-cyclic antidepressants, and these are an old group of drugs that were basically the mainstay treatments of depression from, let's say, from the 1960s into the 1990s, and they were largely replaced by SSRIs. What's interesting is that TCAS are also included for panic attacks, generalized anxiety disorder, PTSD, and a whole bunch of other disorders listed there. The prototype here is imipramine, and some of the other derivatives of that are listed below. And so TCAs, or tricyclic antidepressants, alter both norepinephrine and serotonin due to their ability to inhibit the reuptake of those respective pumps. Chemically, these are secondary or tertiary amines. And so all the monoamine transporters, norepinephrine, dopamine, and serotonin, have the ability to be inhibited pharmacologically. And so there's some crossover with all of these drugs. And this is what this looks like. And so here's the net. Okay, so this is the transporter specific to norepinephrine. And it's similar to in concept, at least, to SSRIs. When you eliminate or when you inhibit the activity of the net, you get less recycling of the catecholamine. So whether it's norepinephrine or dopamine, the point remains the same, is that you essentially get more neurotransmitter postsynaptically available to bind to any of these postsynaptic membrane-bound receptors. If you look at this diagram closely, you can see that NET can be inhibited by tricyclic antidepressants as well as cocaine, which was kind of the original prototype of these drugs, interestingly enough. And in terms of their pharmacology, it's summarized nicely here. But I do want you to know that the side effect profile can be more dramatic in some of the tertiary amines than the secondary amines. And of course, we can pharmacologically classify those by their chemistry, and we'll do so later. But essentially, they offer really good oral absorption. There's a broad spectrum of activity. There's lots of neurotransmitter receptors that they can bind to. Some of them also do affect adrenergic and cholinergic receptors. There are notable CYP biotransformation interactions. But what's interestingly is that the serum levels typically correlate well to the response. And so that's kind of unique in terms of some of the pharmacological agents that we're going to be using in the CNS, where that usually isn't always the case. And so that's at least one good thing about them. Individual notes, I want you to know that amitriptyline offers some histamine receptor activity, so you can bet that it's sedating, which is why we give it at bedtime. Imipramine has some alpha adrenergic activity, as well as some histamine and M1 activity, so you can see orthostatic hypotension, you can see some tachycardia with imipramine. Nortriptyline, which we will discuss, is really the most potent. It has a really nice window of activity. It's pretty predictable in terms of how long it's going to work, and there's typically less side effects. One thing I do want to point out that a lot of these drugs have some cross over in terms of, and you've seen some of this already, in terms of their ability to target or modulate different neurotransmitters. And so this is a nice kind of summary diagram, basically demonstrating that there's a handful of drugs shown at the top that are more norepinephrine selecting, and there's another handful of drugs at the bottom which are more serotonin selecting. And then there's all those drugs in the middle, which are clinically useful but somewhat difficult to put into a category. Also, from a summary standpoint, this is one of the drug lists. I wouldn't necessarily expect you to have this list memorized by the end of the first week of June, but definitely by the end of the month, by the end of June for the final, you'll have a really good understanding of all of these different drugs and drug categories. The drugs that are listed here that are underlined are the ones that you're going to be talking about in the session activity at the end of this week. And so this is the first case. This is for the bipolar case. This is these are the drugs that you're going to talk about in the third activity, in the third session activity. So that was a kind of a quick overview of some of the major drug classes. I just want you to be familiar with them. We will learn all of the pharmacology in the next couple of weeks. I don't want to do it this week. Okay? So please, if there's any questions, email me, let me know, and I hope you are enjoying this block. Thank you.